So now we are going to learn about a very interesting but a difficult topic as far as many of the candidates who are aspiring for endocrinology are concerned, that is laboratory endocrinology. So mostly people will find it difficult mainly because they don't have real hands-on experience. So as in medicine or a pediatrics resident, you hardly get any exposure in the lab. You are not aware of what are the things that are happening behind a hormonal assay, what are the techniques that are used for it, and what are the things that can affect the result of a hormonal assay, and what are the fallacies associated with it. So this lack of exposure is the thing that mainly leads to being laboratory endocrinology often being labeled as a dreadful topic by the students. So here I want to tell you or teach you regarding the basics of laboratory technique, how the tests are being done, what are the principles of those techniques, how the hormones, what are the methods of the usual hormonal assays, what are the fallacies associated with it, and how are you going to overcome them. So I'll be sticking on to the basic aspects and principles so that you will have a sound foundation knowledge with regards to laboratory endocrinology as you enter your DM endocrinology course, and also to make you able to answer all the possible questions which could come out of this topic. So without much introduction, I would go straight into my topic. So first, how this hormone measurement is important in endocrinology, or how this lab is important. You know that endocrinology is a specialty subject that heavily relies on laboratory measurements and hormonal assays. And the patient diagnosis, management, follow-up, everything is highly reliant on these laboratory reports. So it is important to have a good laboratory with accurate hormonal assay techniques without any significant pre-analytical, analytical or post-analytical issues that could alter the reports. So for an example, a patient who is a diabetic who is on follow-up, suppose he is having an uncontrolled blood glucose, he may not always manifest with features of uncontrolled blood glucose like the osmotic symptoms. Many a time he would be apparently normal, and only method with which you can identify an uncontrolled glycemic status is by looking at the labs, the glucose levels, the HbA1c, like that. And of course, in certain percentage of patients, you can get the clinical features also. But many a time, they will be asymptomatic, and it is only the laboratory investigation that would fetch you the correct picture. Same is with many other conditions. For example, in a patient with secondary hypertension, you are evaluating the patient for uncontrolled or resistant hypertension, and you are dependent on your lab, good hormonal assays for the measurement of aldosterone, renin, then catecholamines. So all these have got a lot of variability in their assays. There are a lot of factors that can affect the result of these assays. So unless you got an accurate system and an accurate method to do all these hormonal measurements, it is very difficult for you to get into a correct diagnosis and how to properly manage the patient. Okay, so there lies the importance of the lab in endocrinology as a specialty. Now, if you look at the hormonal assays as a whole, you can broadly classify them based on the methodology into immunoassays and assays based on structure and or charge. So what do you mean by immunoassay? So immunoassay means you are making use of an antigen-antibody reaction. You are making use of an antigen-antibody reaction, formation of an immune complex, and later analysis of that immune complex to get the result of the analyte. That is the basis of immunoassay. Now, the second set of tests include this test which based on structure and or charge. For example, structure, you have the assays that separates your analytes based on the structure, based on the charge, etc. For example, in a patient whom we need to assess the HbA1c, the gold standard for assessment of HbA1c is HPLC, which is the high performance liquid chromatography. And there you are making use of the structure of the analyte. Okay, the differential adsorption of the different hemoglobins are being made use of to identify the HbA1c based on HPLC. You are using the liquid chromatography. And charge based In LCMS, you are ionizing the molecules. You are imparting charge to the molecules and you are separating the individual analytes based on the mass as well as charge. So you have two types of assays. One, the immunoassays, which makes use of the antigen antibody complex, and second, those assay methods that make use of the structure as well as charge of the molecules. Here in this topic, we will deal mainly with the immunoassays because immunoassays are the assay techniques which are available in almost all the centers, and this HPLC and the LCMS. HPLC is more commonly available, but LCMS is available at currently only at Apex institution and only at selected laboratories. In our day-to-day practice, we rely mainly on immunoassays. So I'll be concentrating mainly on the immunoassays, into more of the depths of immunoassays, and only the important points which are exam oriented points will be discussed with regards to the structure and charge based assays. Now coming to the immunoassays. So the history of immunoassay, the landmark event is being marked by these two individuals. So this is Solomon Berson, and this is Rosalind Yalow. So who are these two individuals? These are the one who first introduced radioimmunoassay. So these are the pioneers of hormonal assay or immunoassay in the world. So these two first did a radioimmunoassay for measuring insulin levels. Okay. So insulin was the first hormone to be assayed in our body, and it was done using radioimmunoassay, and it was created by two scientists, Solomon Berson, who was a physician, and also Rosalind Yalow. And for this discovery, this Rosalind Yalow was awarded the Nobel Prize, but Solomon Berson has expired by the time the Nobel Prize was awarded, and there was no posthumous awarding of the Nobel Prize. So he didn't get the award. Only Rosalind Yalow got the Nobel Prize for the invention of radioimmunoassay, and they first did for analysis of insulin. Now, when you say an immunoassay, I've told that an antigen antibody complex is formed. So what are the constituents or what are the components of an immunoassay? The first is an analyte. Okay. Analyte means our target substance which you want to be measured. For example, a TSH or a T4. If you want to check the TSH levels in the blood sample that you have got, then your analyte is the TSH. Okay. So the second component in immunoassay, so there the TSH would be the antigen, and for antigen antibody complex you would require an antigen as well as antibody. So TSH is your antigen, and second is the antibody that binds to TSH. So the most important components of immunoassay include an antigen and an antibody. Third, labeling. What do you mean by labeling? So labeling means you want to identify the antigen antibody complexes that are formed. For that, you will have to label the antibodies with something. So this labeling could be by an enzyme, could be by a fluorescent thing, could be by a radioisotope. So by whatever measure, you want to label the antibody so that when the antigen antibody complex is formed, you are able to identify them. So that is the third thing, which is the labeling. Fourth is you have already labeled and you have prepared, or the antigen antibody complex which is labeled is formed, and now you want to quantify the amount of antigen antibody complex, and then you extrapolate that the result and eventually find out what the analyte concentration is. So you have an analyte, you have an antibody, you have the labeling technique for labeling the antibody, and finally you analyze the concentration of your target substance by using a detection technique. So these are the four components of an immunoassay. And how are you going to detect this antigen antibody complex formation? There are several methods. How you are detecting your antigen antibody complex formation forms the basis of different types of immunoassay. So the formation of antigen antibody complex is the thing which is common to all immunoassays. You have different types of immunoassays, and those types of immunoassay differ from each other in the way how they detect this antigen antibody complex. Okay. So radioimmunoassay means what? you are using a radioisotope to label the antibody, and by using this radioisotope technique, you are detecting the antigen antibody complex. Then you have ELISA, where you are linking an enzyme, enzyme to the antigen antibody complex, and this enzyme is being added, or this is being subjected to another reaction where this enzyme is being acting as a catalyst, and by documenting or by assessing the amount of product formed, you will have an idea about what is the amount of enzyme present in the system. So when enzyme is used as a tag and you are using an enzyme based technique for quantification, it is what we call as ELISA. Then based on fluorometry, you call it as, if you are using fluorinated force, you call it as fluorophores. Fluorinated substances as the label, you call it as fluorometry. Then there is a modification of this fluoroscopic technique, which is the timed resolved fluorescence, which increases the specificity of the assay, which we call as Delphia. You need not know about the details, just learn that Delphia is a type of immunoassay based on this fluorometry. It is an advanced type which increases the specificity of the assay, and this Delphia technique is most commonly used in the evaluation of CAH for analyzing various steroid analytes like 17-hydroxyprogesterone. There are several other conditions in endocrinology where Delphia is used, but this is the most common one and the most validated one for the analysis of the steroid analytes in the evaluation of congenital adrenal hyperplasia. And finally, we have the chemiluminescence, which is by far the most commonly employed immunoassay technique at present in our hospital as well as in most of the laboratories where you send your blood samples. Chemiluminescence, or a slight variant of chemiluminescence called as electrochemiluminescence. Electrochemiluminescence. So these are the techniques which is being followed in most of the laboratories and hospitals across our country. So we will be focusing more on chemiluminescence because the questions are also more into this chemiluminescence or electrochemiluminescence. So what do you mean by this chemiluminescence? Here we are tagging the antibody, or you are labeling the antibody with a substance which can undergo a chemical reaction to emit light. So the higher the concentration of the antigen antibody complex, higher will be this tagged, higher will be this molecule which can emit light. So based on the light emission, based on the intensity of light emission, you can have a surrogate measure on how much antigen antibody complex is there in the assay system. So that is what we call as electrochemiluminescence. Now coming to the types of immunoassays. So as I have told, I will be focusing more on the chemiluminescent immunoassay or electrochemiluminescent immunoassay. CLIA and ECLIA. So CLIA, based on the methodology that is used, you know that it is CLIA, and based on the how the antigen antibody complex is formed, you have classified it into two. One is the sandwich immunoassay. Sandwich immunoassay, also known as the immunometric assay. Immunometric assay. And second is the competitive immunoassay. Competitive immunoassay. So these are two subvariants of our immunoassay. Sandwich or immunometric assay, and second is the competitive immunoassay. We will see what is special about each of this technique. Now coming to sandwich immunoassay. So as the name suggests, here we have an analyte. Sandwich means this analyte is sandwiched between two antibodies. Our analyte of interest, if it is sandwiched between two antibodies, and then this complex, that is one analyte surrounded by two antibodies, this entire complex, when it is formed and detected, that is what we call as sandwich immunoassay. You can see here. So this is our antigen. This is our antigen. Here we have to eventually form a sandwich where the antigen has to be sandwiched between the two antibodies. So our assay platform contains a solid phase. So this is the solid phase. solid phase has got antibodies attached to it, okay, which is called as the capture antibody. So this is what we call as the capture antibody. So capture antibody is the antibody which is attached to the walls of the assay machine. So the assay machine has got antibodies attached to the walls, okay, and to that you add your analyte of interest. Suppose our antigen is TSH. Assume that this is, you want to measure the TSH. For that you add TSH into this assay system, which has already some antibodies which is coated to the walls in a solid phase. So what happens? This antibody will detect specific epitope in the TSH and they will bind. Here the antigen antibody complex has been formed. So the antibody which is present in the solid phase has made a link to the analyte which is added, that is the TSH. Now what you are doing as a second step is that you are adding this second antibody. So first antibody that we have already had there is what we call as capture antibody. Now you are adding the second set of antibodies which is called as the detection antibody. Detection antibody. Why do you call that as detection? Because that antibody has got something attached to it. So here you can see. So this is what we call as the labeled or the detection antibody. And this labeled structure, it could be a radioisotope, it could be a light inducing substance as in chemiluminescent assay, it could be a fluorescent substance, it could be an enzyme which is linked to the antibody. Okay. So first you have a solid phase antibody which is the capture antibody, then you add the antigen, then you add the second antibody which is linked or which is labeled to a labeling agent. Okay. So you had detection antibody. Now what happens? This detection antibody can detect a separate epitope of the same antigen. So suppose a TSH has got multiple antigenic epitopes. Then your capture antibody would detect one epitope and it will bind to that, and your detection antibody will bind to another epitope of your antigen. So what happens? Eventually you will have this TSH which is sandwiched between two antibodies, your capture antibody and detection antibody. So once you have done this process, then what you will do is that you will do washing on this assay system. So once washing occurs, what happens is that those antibodies which have not yet formed the antigen antibody complex will be washed away, and what remains will be the antigen antibody complex. So after washing, what remains will be the antigen antibody complex only. So after washing, only the antigen antibody complex will be remaining and everything will be washed away. So then you will measure what is the antigen antibody complex concentration. So here, as you can see, if the TSH concentration was very high in this sample, then the amount of antigen antibody complex formation would also increase. So when you plot a graph between the bound label means it is a marker of the antigen antibody complex formation in the y-axis to the x-axis, which is the concentration of the antigen. So when the bound label, when the antigen antibody complex detection increases, that means concentration of the antigen in the original sample was also very high. So in a competitive immunoassay, concentration of the antigen is directly proportional to the detected label. Very, very important. This is directly proportional. So I would once again just repeat the steps. First, the sample is added to the capture antibody fixed on a solid phase. Okay, capture antibody fixed on a solid phase. Then second, what happens? The antigen binds to the capture antibody. And third, you add a labeled antibody which bind to another site on the antigen, and thus an immune complex is formed, and this immune complex is detected by any of the detection techniques based on the assay platform. If it is a RIA, then that is based on the radioisotope detection. If it is an ECLIA, it is based on the amount of light which is generated from this antigen antibody complex, like that. Now, let's see what actually happens in an ECLIA. So, what do you mean by ECLIA? ECLIA means an electro chemiluminescence. What do you mean by electro? Electro means it is electrochemically initiated chemical energy, and this chemical energy is emitted in the form of light, okay, which undergo luminescence. So what exactly happens is that here you have the capture antibody, here you have the antigen, this is the detection antibody, okay. Two green are the capture antibody and the detection antibody, and this detection antibody is labeled to something called as a ruthenium. So this is again labeled to another antibody which contains ruthenium. Okay, ruthenium is an element in the periodic table, and what happens is that this assay system contains buffer, okay, for neutralizing, for maintaining the optimal pH. This buffer contains excess of an substance called tripropylamine. What this tripropylamine does is that it will emit electrons. It acts as an electron donor. Okay, it acts as an electron donor. So there is too much of electrons being donated by this tripropylamine, and in order to maintain this electrical neutrality, this ruthenium also would emit an electron, and it becomes ruthenium. Initially it was ruthenium 2 plus, it becomes ruthenium 3 plus. Okay, so ruthenium 2 plus becomes ruthenium 3 plus, and ruthenium 3 plus is a highly unstable compound, and it would try so much to come back to its stable state, which is ruthenium 2 plus, and it would spontaneously go back into ruthenium 2 plus, and during this process it emits lights. So what is actually the light emitter in an electrochemiluminescent assay? It is the ruthenium. That is the nutshell. Okay, so ruthenium is being linked to our detection antibody, and this ruthenium goes into the excited state due to the emission of electron, and when it comes back to the stable state, it emits light, and this light is detected by the light detectors within the assay platform, and assessing the intensity of the light, you will get a surrogate measure of the amount of antigen antibody complex which is formed within the system, and thereby you will get an idea regarding the analyte also. So this is what is happening. This is an example of what is happening in a chemiluminescent assay done using a sandwich immunoassay. So again, I want to emphasize this point is that in sandwich immunoassay, the signal that you detect, signal is a measure of the antigen antibody complex. It is directly proportional to the concentration of the analyte. Very, very important point. Now, what are the features of sandwich immunoassay? Or for what all analytes is sandwich immunoassay useful? 1. Sandwich immunoassay is used for larger molecules. Large molecules. Why it is used for large molecules? It is because we have to have two antibodies binding to a single antigen. So in order to have enough space or enough antigenic epitopes for binding two antibodies, this molecule should be a large one. So large molecules with multiple epitopes are the ones which are eligible for sandwich immunoassay. Very small molecules like free thyroid hormones cannot be measured using sandwich immunoassay due to the smaller size and due to the lesser antigenic epitopes. So large molecules are measured using sandwich immunoassay. So here sandwich immunoassay is more specific and it has lower detection limit. So lower detection limit means even when this analyte concentration is very low, this assay can go and determine that. That means the assay is very good. Okay, so why is it so? Because here you are using excess detection antibody is used in sandwich immunoassay so as to make sure that whatever antigen is there in your assay is being all bound by an antibody and no antigen is being missed out. Okay, so that gives more specificity to the assay, and the detection limit is also lower. That means the assay would be more robust in a case of sandwich immunoassay. And third is the formation of a steady state system. Why there is steady state is because there is no competition happening in sandwich immunoassay. A steady state means an antigen antibody complex will be formed and it will keep on forming until all the antigen is being sandwiched between the two antibodies. Afterwards, there is no change happening. Okay, because all the antigens are being sandwiched by the two antibodies, so that there is no more antigen antibody complex which is formed, and whatever formed is not dissociating also. So there is a steady state formation. Whereas if two things are competing for a single target, a steady state will not be obtained, because during competition one may win whereas the other is still competing, and the other may displace this from the binding. So where if two things are competing for a single target, then the steady state cannot be achieved. But here, even though there are two antibodies, but it is not competing against each other. Why? Because they have the target to the different epitopes. If two antibodies were to bind to a same epitope in that TSH antigen, then it would have become a competitive one. But here it is not competitive because the antibodies are binding to different epitopes. So no competition is occurring and there is a formation of steady state in this sandwich immunoassay. So these are the most important attributes of a sandwich immunoassay, because you have large molecules can be assayed. The assay is more specific and the assay would have a better or lower detection limit, and there is a formation of a steady state which again makes the assay more accurate. Now, which are the analytes measured in sandwich immunoassay? Very important. The question that you are going to get is most likely in this line. Like this analyte they will give in the exam, which would be the best immunoassay technique, or which is the type of immunoassay that will be employed for detection of this analyte. Okay. So the larger hormones like the pituitary hormones, which are those the LH, FSH, ACTH, TSH, all are measured using this sandwich immunoassay because they are large peptides. Then you have PTH, calcitonin, then you have insulin, IGF-1. So your GH also is measured in sandwich. Then you have AMH, inhibin. So all those larger glycoprotein and polypeptide hormones are measured using this sandwich immunoassay. Okay, after you have learned competitive immunoassay, we can compare between those two assays and what are the analytes which can be measured in each of these platforms. Okay, so these are the analytes measured in sandwich immunoassay. Okay, so these are the examples. Okay, there are so many others also. These are some of the examples which I have just thought in your mind. Now, that is about sandwich assay. Now coming to competitive immunoassay. So competitive immunoassay, as the name indicates, here two things are competing for a single target. Whereas in sandwich there was no competition like that. Here two things are competing for a single target. Now let's see. So a prototype of the analyte that is measured using competitive immunoassay is T4, okay, which is the thyroxine. So here what you are doing is that, so in this figure, green refers to labeled antigen and this red refers to analyte. So red is the T4 present in the patient's blood. Now you are adding the patient's blood into the assay system and you are also want to measure the T4 in the patient's blood. And that your analyte of interest is T4, and for measuring T4 you are also adding labeled T4, okay, labeled T4 into the assay system. And in the solid phase you have the capture antibody, and this capture antibody is having affinity to a single epitope in the T4. So this epitope can bind to either the patient's T4 or the labeled T4 which we have added. So both this labeled T4 and the patient's T4 will compete to bind to the capture antibody. Okay, so here there is a competition happening between the labeled and non-labeled. Non-labeled means the patient's analyte or the patient's blood. There is a competition for a single antigen binding site in the antibody. So what happens eventually? Some of the antibodies would be bound to the labeled, some of them would be bound by the patients. So there would be, these antibodies would be interspersed. Some will be bound by the analyte antigen, some will be bound by the labeled. Now, then you will detect the labeled antigen antibody complex. Okay. Now, this, our detection technique can detect only the antigen antibody complex which is labeled. So here, this is the red is the one which is the analyte, which is the patient's blood, and green is the one which is labeled. Okay, green is the one which is labeled. So when you start measuring it, the assay platform can detect only this green, because only the labeled antigen antibody complex can be detected by the assay platform. So here this will be detected. So when you draw the calibration curve, you can see here when the signal increase, when the signal is very high. What do you mean by the fact that when the signal is very high? When the signal is high, it means that the antigen antibody complex is formed mostly by the labeled antigen and the capture antibody. Why has that occurred? Because the analyte concentration in your sample was low. So the concentration of the analyte was low. That means it was not able to compete effectively with the labeled antigen. That's why the labeled antigen antibody concentration was very high. Now, suppose if the labeled antigen antibody concentration was very low, what is the inference? It means that our sample, the patient sample, contained very high levels of analyte. That means it had made complex with the antibody, so that the antigen antibody complex formed were mostly unlabeled, which went undetected. So that means you are having an inversely proportional relation between the signal and the analyte concentration in competitive immunoassay. This is an extremely important concept. So signal directly proportional to analyte in competitive immunoassay, in sandwich immunoassay, and signal is inversely proportional to analyte in competitive immunoassay. So this is an important point that you should take note of. So I hope you have got the concept behind the sandwich as well as competitive immunoassay. Now let's look at properties of compounds which are measured using competitive immunoassay. They are more likely to be small compounds, small molecules, and the assays are less specific. So it doesn't mean that the competitive immunoassay is not good. It means that the specificity may not be as good as a sandwich immunoassay. Okay. Then steady state not achieved. Steady state not achieved. Okay, these are the important properties. Now coming to the examples of analytes. So the examples include steroid hormones, T3, T4. So steroid hormone means the cortisol, the aldosterone, the testosterone, estradiol, all the androgenic hormones like that. So all those, then the T3, T4, vitamin D are all measured by competitive immunoassay. And one more thing which is measured by competitive immunoassay are the important antibodies, namely anti-TPO, TSH receptor antibody. So these are also measured by competitive immunoassay. Now you should compare the analytes measured with competitive immunoassay to that of sandwich immunoassay. Okay, the steroid and the steroid-like compounds are measured using a competitive immunoassay, and sandwich immunoassay measures polypeptide and the glycoprotein hormones. And of note, antibodies, the anti-TPO and the TSH receptor antibodies are also measured by competitive immunoassay. Now, we have learned about the basic functioning of sandwich and competitive immunoassay. Now, let's see what are the things that say that performance of an assay is good or bad. So, to note whether the performance of an assay is good or bad, there are several parameters like the accuracy, the precision, the linearity, the limit of detection, quantification, specificity, range, etc. Okay. So, I will emphasize on certain things which are more clinically relevant and has been asked previously in the exam also. What do you mean by accuracy and precision? When you just hear these two terms, you may think that these are synonymous, but they are not actually, and they have a very different meaning with regards to an assay. So what do you mean by accuracy of the assay? What do you mean by precision of the assay? So accuracy means, suppose a patient, we are checking the serum cortisol level in that patient. So if the level of cortisol measured by LCMS, so the measurement by LCMS, which is the liquid chromatography mass spectroscopy, is the gold standard for cortisol measurement. We have done LCMS for that patient and the sample contains 15 micrograms per deciliter of cortisol. I am giving you a hypothetical situation. Okay, 15 microgram per deciliter of cortisol. Now you are using your immunoassay to find out whether the assay is accurate and precise. Now, the accuracy means closeness of the measured value to the actual value. For example, if you are using a competitive immunoassay to detect a sample which contains cortisol of 15 micrograms per deciliter, and the assay report from the competitive immunoassay is 14.9 microgram per deciliter, and another assay that we have used is showing 12 microgram per deciliter. Okay, 12 microgram per deciliter. So accurate means how close the measured value is to the actual value. So among these two assays, which would be the more accurate one? It is the assay which had showed 14.9 microgram per deciliter, because it is the closest to the actual measured value of 15 microgram per deciliter. So that is accuracy. How close your measured value is to the original value. Now, what do you mean by precision? Okay, what do you mean by precision? So, suppose in the first assay, which has showed 14.9 microgram per deciliter, okay, again and again that same sample is being repeated for cortisol. The first value was 14.9 microgram per deciliter. Second value was 15.7 microgram per deciliter. Third value was 14.3 micrograms per deciliter. 14.3 micrograms per deciliter. And you have done the second set of values also based on the second assay, and the values, first value was 12 microgram per deciliter, second was 11.9 microgram per deciliter, third was again 12 microgram per deciliter. So if you analyze these three reports, you can see that your actual cortisol value in that patient is 15 microgram per deciliter. Okay, there is no question, there is 15 because we have measured it using LCMS. When you compare these two set of result, which is more accurate? Definitely this. Okay, this is more accurate because this set of values are lying more close to the original value of 15. There is no question. Now, which is more precise? Precise means, the precision means the repeatability. When you are doing the same test again and again from the same sample, how close your repeat value is to the original value. So here the original value was 14.9 in first assay, and when they have repeated it became 14.7, 15.7, and then again repeated it became 14.3. Whereas in the second set, the original value was 12, second was 11.9, and third was 12. So here the first assay is more accurate because it is more close to the original value, whereas the second set of values is more precise. Why? Because it has got good repeatability. Even when you do repeated measurements, the values are holding close to one another. So this diagram clearly says this. So this is your target. Okay, your target. So here the values are clustered to one another. When the values are clustered to one another, you can say that it has high precision because the repeatability is good. He is continuously throwing things in the same direction, but the direction is wrong. Direction is wrong means the accuracy is low, but precision is good means he is doing things in the same way. Okay, the repeatability is good. So this diagram shows a low accuracy with high precision. So here it is high accuracy because all the individual parameters are close to the target, but they are different from one another. So the precision is not very good, precision is low, but the accuracy is good. So this is high accuracy, high precision. It is in the target and everything are close to each other. So low accuracy and low precision means it is widespread everywhere and there is no repeatability also, there is no closeness to the actual value. So you want an assay with high accuracy and high precision. Oh, okay. High accuracy and high precision are the ones that are wanted of a ideal assay. So this point is being repeatedly asked. What do you mean by accuracy? What do you mean by precision? You should not confuse between these two terminologies. Now, extremely important concept. There are three things. The limit of blank. These are again the attributes of an assay. What do you mean by limit of blank? What do you mean by limit of detection? What do you mean by limit of quantification? Now, I would like to explain these concepts based on cortisol. Okay, cortisol. So, we have a patient whom we have taken the blood sample from and we have done the LCMS, and based on LCMS, the serum cortisol was 10 micrograms per deciliter. Okay, 10 micrograms per deciliter. Now, first you decide to check about the robustness of the assay. For that, in the assay platform, instead of the blood or the serum of the patient, you are keeping plain water. Okay, you are keeping plain water instead of the patient's serum. So, what do you expect the serum cortisol level would be from plain water? You expect it to be 0. Okay, you expect the serum cortisol level in a plain water to be 0. But surprisingly, it comes back as a value like 0.08 or 0.09, something like that. So you will be surprised. You don't expect serum cortisol to be present in plain water, distilled water, but you are getting a value. This is what you call as limit of blank. Limit of blank means the value that shows up in a sample that doesn't contain your analyte of interest. You check for serum cortisol in a sample that doesn't contain cortisol and you still will end up with a value. That is called as limit of blank. So that is the first concept, which is the limit of blank. Now, second is the limit of detection. So limit of detection means the lowest concentration of an analyte that can be detected by the assay. For example, for cortisol, the standard limit of detection in immunoassay ranges from 0.054 to 63.4 micrograms per deciliter. So below that and above this result, the assay will not show up a value. Okay. So less than 0.054, you cannot get the report. Less than 0.054. Suppose if the cortisol concentration in that sample was 0.03, then you will not get the report. Why? Because it can measure only from 0.054. The assay is not sensitive at very low concentration to detect that. So that is what we call as limit of detection. The limit of detection is the lower limit where the assay can detect an analyte concentration. It is not the limit of blank where there is an erroneously shown up report. Okay, this is actually the analyte that the assay is measuring, but it can measure only from a certain concentration. Now, what is limit of quantification? So, how the limit of detection is different from limit of quantification? So, limit of quantification again means it is the lowest concentration of analyte which can be reliably assessed, which can be reliably measured. So the most important point in this is the reliably measured. Why? I will give you an example. Suppose you are checking a sample which contains a cortisol concentration of 0.06 microgram per deciliter. 0.06 microgram per deciliter. So 0.06 means it is above the 0.054, which is the lower limit of detection. So when you do the assay for the first time from the same sample, the report may come as 0.08. Second time may come as 0.054. Third time it may come as 0.09. So there is actually a difference from the actual value, so that at lower concentrations, even though the assay can detect, but the assay will be less accurate. Okay, the accuracy will vary. So instead of the actual 0.06, from the same sample, if you are repeatedly doing test, it is showing up different result. So it just means that at very low concentrations, the assay is less accurate. It can vary. It can diverge from the original value. Whereas limit of quantification means the level above which the assay has got good accuracy. For example, the limit of quantification in a cortisol assay is around 0.1 microgram per deciliter. That means when the value is more than 0.1 microgram per deciliter, the values will be accurate. There will not be a wide variation from one another. Below 0.1, these values can fluctuate. Even though the assay can detect, there will be wide variation. Whereas above the limit of quantification, this assay will be more accurate. So this lower limit above which the assay can detect the analytes with accuracy is what we call as limit of quantification, and the other name given to limit of quantification is functional sensitivity. Functional sensitivity. So this is really a potential question. They can ask either functional sensitivity or as a limit of quantification. So it is the lowest concentration of the analyte which can be reliably measured. Limit of detection means which can be measured, but that adjective reliably is missing in limit of detection. It just can detect, but when you recheck with the same sample, it may turn out to be a different result. Okay. Now, what do you mean by coefficient of variation? So, coefficient of variation means how much the repeated values differ from one another. Okay. Now, when you are doing a competitive immunoassay for cortisol, that takes around 20 to 25 minutes. Okay, 20 to 25 minutes for one run. And in this one run, you can keep multiple samples. Suppose, for example, a competitive immunoassay machine can measure 10 cortisol samples at a time. 10 cortisol samples at a time. So 10 samples you can measure at a time, and if you want to measure the 11th sample, you would have to wait for this 25 minutes to be over. You finish the entire batch and you have to start a fresh batch. Okay. So that is the principle. Now, you have two variability, which is inter-assay variability and intra-assay variability. So what do you mean by this inter-assay and intra-assay variability? So intra-assay means you are having some 15 ml of blood taken from a patient. Okay, 15 ml of blood, and you have divided them into 15 equal proportions of 1 ml each. And a blood content as small as 1 ml would be able to give you the cortisol report. Okay, so you have 15 portions of blood from a patient, and you can measure only 10 cortisol samples at a time. So from that same patient, the same sample you have split into 15, and the 10 of those is going as the first batch. Okay, and if the original cortisol measured by LCMS is around 10 micrograms per deciliter, but that doesn't mean that all the 10 samples that we are measuring by competitive immunoassay will come back as 10. We have learned about the accuracy and precision, right? So based on the accuracy and precision, the values will vary. So the values could come as 9.6, 9.8, 10.2, 9.5, like that. Okay. So how much these values vary from each other when they are analyzed together in a same batch is what we call as the intra-assay variability. You are measuring the same sample in the same batch, but still they differ from each other. This is what you call as intra-assay variability. So a good assay should have an intra-assay variability of less than 10 percentage. Less than 10 percentage. Now, what do you mean by inter-assay variability? So, inter-assay variability means here I've told you you have made 15 portions of the patient's sample. 10 portions you have done as the first batch. Okay, and the next 5 you are doing as the second batch. But it is the same sample, you should remember, which contains the 10 microgram per deciliter cortisol. Now, that result may turn out as 11.5, 10.6, 10.4, 10.8 like that. Okay, now inter-assay variability means how the analyte result in the first batch of the same sample is differing from the second batch of the same sample. That is what you call as inter-assay, because you are running the assay at different times. So the factors that can alter the hormonal result is also vary. So inter-assay means you are doing the sample running separately batch after batch, and you compare the values between batches. That is what is called as inter-assay variability, and this inter-assay variability should be less than 15 percentage. So this is what you call as coefficient of variation. So I want you to understand these concepts. That's why I have explained this in detail. Okay, so you have inter-assay variability that should be less than 15 percentage, and intra-assay variability that is less than 10 percentage. These are the attributes of a good enough assay. Now, errors in hormonal assessment that can occur at multiple levels. It could be pre-analytical, analytical errors, and even post-analytical. Pre-analytical means you are not collecting the sample properly. For example, in calcium, you are using tourniquet, and that is causing the release of the bound calcium, and the free and the bound fraction varies, and you are getting an erroneous report. Or you are not collecting the sample properly as in the proper test tube. You are not maintaining the cold chain for ACTH or PTH sampling. Then the errors in hormone measurement occurs. Those are pre-analytical. Analytical means it is the actual interferences that occur during the assay. And then you have post-analytical errors where you have a mismatch between the sample and the name, and issuing of report there is something error which is creeping up. Those are the post-analytical errors. So it can occur at any levels of hormone measurement. So here we will be focusing mainly on the analytical errors that can interfere with the assay techniques. So one of the important analytical errors is the cross reaction of analytes. So what do you mean by this cross reaction? In immunoassays, you are making use of the antigen antibody complex, and in the antigen, this antibody has the affinity to certain epitopes, and these epitopes may not be specific to that antigen alone. For example, in a case of cortisol, you want to measure cortisol, but the patient has excess 11-deoxycortisol. 11-deoxycortisol. Then the antibody which is supposed to bind cortisol can bind to the antigenic epitope in the 11-deoxycortisol also. So the assay platform will falsely detect 11-deoxycortisol as cortisol, and it would give a high report. The similar cross reaction can occur with prednisolone, the patient on prednisolone therapy, methyl prednisolone therapy, but not with dexamethasone, because the dexamethasone has a antigenic epitope which is distinct from that of prednisolone or a hydrocortisone. So the cross reaction of analytes is a serious problem. Estradiol, there can be cross reaction, for example, in patients who are taking fulvestrant. So fulvestrant is a competitive antagonist of estrogen for binding to the estrogen receptor. Both of them have structural similarities. So the antibodies can bind to both estradiol and fulvestrant, giving you a false report. So like growth hormone, if the patient is on pegvisomant, this pegvisomant could be detected by the assay and it will be labeled as growth hormone. Insulin, the exogenous insulin as well as insulin receptor antibodies, all these can interfere with the assay. So that is the cross reaction of the analytes which can cause an analytical interference. Now, hook effect we have studied in detail under the prolactin module. So synonym is the prozone phenomenon. Prozone phenomenon. What is the cause? The cause is the presence of excess analyte. The analyte concentration is increased so much so that it saturates detection antibody. Okay, it saturates detection antibody. How it occurs, we will see. And one very important point is that this hook effect is exclusive to sandwich assay. So those analytes which are measured using competitive immunoassay are immune to hook effect. So why is it exclusive to sandwich immunoassay? So that we will learn about when you discuss the mechanism. Okay. Now the hormones that exhibit hook effect. So hook effect, what do you mean by basically the hook effect? We have learned that when there is very much high concentration of the analyte, but in the assay it shows up as a false low report. Okay. So the most important hormone is prolactin, the others being HCG, then calcitonin. Then this can be exhibited by hormones like PTH also. So prolactin, HCG and calcitonin are the hormones that exhibit hook effect to the maximum, and also thyroglobulin. Okay. So thyroglobulin, calcitonin, HCG, prolactin, PTH, etc. are the hormones that exhibit hook effect when actually the analyte concentration would be very high, but that would show up as a false low report. So now looking at why is it happening? Now let's look at what exactly is happening in hook effect or prozone phenomenon. So it occurs exclusively in sandwich immunoassay. You know that in sandwich immunoassay, for the analyte to be determined, it has to get sandwiched between the capture and the detection antibody. But in hook effect, where the analyte concentration is very high, this sandwiching is not happening. The analyte concentration is so high that it binds to the capture antibody and detection antibody separately, and this sandwich formation is not happening. And when you do the washing step, all these things get washed away. All the detection antibodies and the free analytes are getting washed away. Only the capture antibody bound with the analyte will remain, but that will not be detected. Only this will be detected. Okay. Only this sandwich formation, which is very less, will be detected. So when actually the prolactin concentration may be 20,000 nanogram per ml, the actual value may show up as 5 or 10 nanogram per ml. It is due to this hook effect or prozone phenomena. Mainly done, you have to keep in mind 2 or 3 points. One, it is seen exclusively in sandwich immunoassay. It is seen when the analyte concentration is very high, and the false very high levels of analyte would produce a false low analyte report. Now, how can we rectify? How can you rectify this hook effect? It is by serial dilution. So when you serially dilute the sample, that would actually reduce the analyte concentration, so that this interference with the detection antibody is not happening and you are getting the accurate result. So serial dilution is how you rectify the hook effect correction. Now, conditions where hook effect is unlikely. One, all the assays which are done using competitive immunoassay, there will not be any hook effect. Then even in those with sandwich immunoassay, hook effect has never been reported. Cushing disease, and it also has not been reported with acromegaly. Why? Because for hook effect to occur, the analyte concentration would be 4-digit or even 5-digit values. The prolactin would be 10,000, 20,000. Likewise, the HCG would be in lakhs. The calcitonin would be in 10,000 or 20,000 for the hook effect to happen. Whereas in Cushing disease, the ACTH level, maximum ACTH would be less than 1000 picogram per ml. Less than 1000 picogram per ml. That too in rare conditions of ectopic ACTH production. The pituitary Cushing disease, the ACTH levels would always be less than 100 picograms per ml. It will not be 3-digit values usually. And similarly in acromegaly, growth hormone levels rarely exceed above 100 nanogram per ml. So in those two situations, the hook effect is unlikely, mainly because such extremes of hormone production is not experienced with Cushing disease or acromegaly. Now, what about the interfering antibodies? So, in a sandwich immunoassay as well as competitive immunoassay, we are making use of antibodies which targets the specific epitope of our antigen of interest or the analyte of interest. But sometimes the serum of the patient contains certain other antibodies which can also bind to our analyte of interest, thereby it distorting the original result. So these interfering antibodies can be heterophile antibodies, anti-animal antibodies, or rheumatoid factor. So these heterophile antibodies, they are usually polyclonal. Polyclonal means they can bind to different analytes. They don't have a specificity to a single antigenic epitope. They can bind to multiple antigenic epitopes. The anti-animal antibody, it occurs usually following our exposure to certain antigen from the animals. For example, after drinking cow's milk, eating certain meat, getting some vaccinations like that. Okay, so anti-animal antibodies, they are more likely to be monoclonal and specific. Monoclonal and specific. Then you have the rheumatoid factor, which is the IgM antibody against the Fc portion of the immunoglobulin. Okay, so all these antibodies can interfere with our analyte assessment. It can occur in both sandwich as well as competitive immunoassay, and it can distort in all possible ways. Sometimes it can produce a false positive, sometimes it can produce a false negative also. Okay, so both false positive and false negative are possible with these interfering antibodies, but the most common pattern with an anti-animal antibody, rheumatoid factor, or an heterophile antibody is false positive or a false increase. So this you should keep in mind. So when an analyte is falsely elevated or falsely increased, then the interfering antibody should be kept as one of the diagnostic possibilities when the patient doesn't have any clinical symptoms or there is a clinical biochemical discordance. You should think of these laboratory interferences, and these interfering antibodies usually produce a false positive. Now coming to macro hormones. So what do you mean by this macro hormones? These are nothing but hormones bound to immunoglobulins. So why are they bound to immunoglobulins? Because this is mainly because of the altered post-translational modification. You know that the hormones are initially being released as a pre-pro hormones, then as pro hormones, and finally into the mature hormones. So there is a lot of editing process that is happening, and there are certain post-translational modifications also. So sometimes these normal modifications may not occur and certain abnormal modifications may take place. So these abnormal modifications can make this antigen or make this hormone more antigenic, thereby attracting the circulating antibodies. So what happens or what eventually result is that these immunoglobulins will come and bind to these hormones, and this immunoglobulin binding can also result a false positive elevation of the analyte. So these macro hormones are described mainly with two hormones. They are prolactin and TSH. There are a lot of other hormones also that can exhibit this phenomenon, but most commonly it is present with prolactin as well as TSH. You call that as macro prolactin and macro TSH. So how they would manifest? They would manifest as high analyte concentration without any clinical features. The patient, a female, would be undergoing prolactin testing for some non-specific conditions like infertility or PCOD like that, and the prolactin level may come as 300, 400 or 500, which is consistent with a diagnosis of macroadenoma or a pituitary tumorous lesion. But again, the patient is not having any specific features like galactorrhea or menstrual disturbances like that, and the MRI that you are taking is not showing any lesion also. In such conditions, you should think of the possibility of a macroprolactin where there is a false elevation in prolactin due to the immunoglobulins which is binding to the hormone. And how are you going to rectify this macroprolactin? This is by doing a polyethylene glycol precipitation. So what do you mean by this polyethylene glycol precipitation? Here in this figure you can see the analytes are being bound by immunoglobulins, and when you add polyethylene glycol, it can precipitate all these antibodies. So this polyethylene glycol will bind to all these antibodies and they will get deposited at the bottom. They will get deposited at the bottom so that the supernatant is containing the original hormones on it. So how can you make a diagnosis of macroprolactin? It means that suppose after polyethylene glycol precipitation, if repeat and antigen testing on the supernatant is less than 40 percentage of the original report, then you can make a diagnosis of macroprolactin. Suppose if the original prolactin value which was due to macroprolactin was 100 nanogram per ml, then you do a polyethylene glycol precipitation which would cause the precipitation of all the immunoglobulins and thereby giving you the actual prolactin report. And when the repeat prolactin, suppose if it is 25 nanogram per ml, repeat prolactin after PEG precipitation is 25 nanogram per ml. So there is a 75% reduction. So the 75% reduction is there and the current value is only 25% of the original value. So it is less than 40. So we have made a diagnosis of macroprolactin. Now coming to the interference of biotin. You know, biotin is a vitamin and it has been given as an over-the-counter preparation in so many conditions like hair fall, for nurturing the skin and in some neurodegenerative conditions. So the recommended daily allowance of biotin is only around 35 to 30 micrograms. But when you are taking large doses of biotin like 5 milligram, 10 milligram or 20 milligram, this biotin can interfere with the immunoassay. Let's see how. So we have learned that in sandwich immunoassay as well as in competitive immunoassay, both have a solid phase, right? Solid phase which contains the capture antibody. Detection antibody is present only in sandwich immunoassay, whereas capture antibody is present in both sandwich as well as competitive immunoassay. So how is this capture antibody fixed to the solid phase? Okay, it has to be fixed to the solid phase, right, in order to make it immobile. So this fixing is made possible by the biotin-streptavidin interaction. This solid phase of the assay well is coated with streptavidin and this capture antibody is labeled with biotin. Okay, so this capture antibody has a biotin here and this streptavidin will attach it to the solid particles. That is how this capture antibody is kept immobile. Okay, the biotin in the capture antibody is linked to the streptavidin of the solid phase of the assay well. So that is how this capture antibody is immobilized. Now, when the patient's blood contains so much of biotin, the free biotin is there, this free biotin would interfere or will compete with the biotin-related capture antibody for binding to streptavidin. So what happens? This free biotin will come and bind to the streptavidin and this capture antibody will be released from the solid phase. Only when the capture antibody is held stationary, then only the antigen can come and bind to it and the detection antibody can subsequently bind and form a sandwich to detect the analyte. But here the biotin is displacing the capture antibody, so there is reduced sandwich formation and consequently the assay will show that the analyte concentration is less. So the biotin will cause false low value in sandwich assays. Similarly, this binding is exactly the opposite in the competitive immunoassay. There also it will displace the capture antibody from the solid phase and there will be reduced antigen antibody complex detection. But according to the calibration rule that we have studied in competitive immunoassay, we are assuming that as the antigen antibody complex formation is reduced or the signal is reduced, the analyte concentration is assumed to be high. So what you interpret from the biotin interference in a competitive assay is that there also the signal is getting reduced, but you will be getting the report as high because there is inverse relation between the signal and the analyte measurement. So there will be false increase in competitive assay. So this is what is happening in biotin interference. Okay, whatever analytes which are measured using sandwich assay would show up a false low value and competitive assay would show a false high value. This is typically seen in a patient who is undergoing thyroid function test. In thyroid function test, as you know, TSH is measured using the sandwich assay. So TSH would come back as low, and the T4 and T3, even the TSH receptor antibody may show up as false positive because they are measured using competitive immunoassay. So T4 and T3 also increased. So this is the effect of biotin, and the patient would have no clinical features. So how can you avoid that? You have to avoid biotin for at least 48 hours prior to collection of the sample for assay. So that is how you rectify the biotin. And this biotin interference is not exclusively for the thyroid function test measurement. You can get vitamin D excess like report because the vitamin D is also measured by competitive immunoassay. You will get a false high report, and you will get low PTH, you would get low ACTH with biotin, all because it is measured using sandwich immunoassay. So that is the importance of biotin, and you have to know about what is happening within the assay system in a patient on biotin, because that you may get as a true false question. So just learning it will produce false negative and false positive in sandwich and immunoassay, competitive immunoassay respectively, may fetch you the mark, but sometimes the question can be more conceptual based. So understanding the physiology is also very important. Now what are the other interferences? So with regards to thyroglobulin, you can have anti-TG antibodies. So anti-thyroglobulin antibodies can be there, and this anti-thyroglobulin antibodies can result in a false negative thyroglobulin. False negative thyroglobulin. Okay. False negative thyroglobulin. So this is an exception to the antibody interference that we have studied, because the antibody interferences that we have studied was of non-specific antibodies. But here this specific anti-TG antibodies, they will bind the thyroglobulin so that the thyroglobulin is not available to be formed as a sandwich. Okay. In immunometric or the sandwich immunoassay, this anti-TG would bind and neutralize the thyroglobulin so that the thyroglobulin is not able to be bound by the capture and the detection antibody, and that sandwich is not formed. So you will get a false low thyroglobulin. And insulin, you have the anti-insulin antibody, which causes a false positive result. False positive result. And paraproteinemia, you know, the antibody concentration, there will be hyper gamma globulinemia. The antibody concentration would be high, and therefore false high can occur in all the assays. So a patient undergoing any assay, they can have a false elevation due to paraproteinemia. Now summarizing all the assay interferences that we have learned so far, biotin, you can have false increase in competitive and false low in sandwich assay. You can have other interferences also, like anti-streptavidin antibody, then anti-ruthenium antibody. We have learned about anti-ruthenium, right? And ruthenium is the label which is used in the detection antibody, which eventually emits light in chemiluminescence assay. So all the anti-ruthenium antibody, anti-streptavidin antibody will produce a result similar to that of biotin interference. Okay, yeah, you just have to keep that in mind. False low in sandwich and false high in competitive immunoassay. That is common to biotin, anti-streptavidin and anti-ruthenium antibody. Then hook effect, there will be false reduction. Then cross reaction, we have learned about it. Macroanalyte, there is false elevation. And how do you rectify macroanalyte? By doing a Peck precipitation. And the gold standard method for rectifying macroanalyte is gel filtration chromatography. So gel filtration chromatography is the gold standard method, and Peck precipitation is the standard procedure that you are performing. Then anti-insulin antibody, it would cause a false elevation. Anti-TG antibody, it would cause a reduction. Heterophile antibody, it usually increases, but rarely it may reduce also. Then gammopathy, that means paraproteinemia, usually it causes a false elevation in all the assays. Then familial dysalbuminemic hyperthyroxanemia, we have discussed under the thyroid case studies. The free T3 and free T4 are erroneously increased. It is just a laboratory interference. In vivo, within our body, only the total T4 and T3 is increased. The total free T4 and free T3 would be normal. But when you do an assay in vitro, that would free T4, free T3 may also be shown as high, which is a false high. Now, about coming to LCMS. So LCMS, very few points has been asked so far. Those points that you need to know are, it is the most specific method, most specific and accurate method for analyte measurement. Okay, most specific and accurate method. So whatever analyte that is being given in your exam, they are asking which is the most specific method. You can readily go and write LCMS with 1 or 2 exceptions that I will mention. Okay, most specific and accurate, and it contains 2 parts. One is the liquid chromatography and next is the mass spectroscopy. What happens in liquid chromatography is the initial separation of the compounds is happening. For example, you are evaluating a patient with CAH and you have to assess the steroid profile. So when you are assessing the steroid profile, you are looking into the various metabolites like pregnenolone, then 17-hydroxyprogesterone. You are looking at androstenedione, you are looking at DHEAS, you are looking at 11-deoxycorticosterone. So many steroid metabolites you are looking at. So first, you are allowing them to pass through a chromatographic column. So based on the chromatographic column and the variabilities in the absorption, an initial separation of the analytes is happening, but that is not very accurate. The chromatography alone is not a very accurate thing for separation of things, or nor can you quantify it accurately. So after the initial separation based on the liquid chromatography, this is passed into a mass spectroscopy unit. What happens in mass spectroscopy unit is that these individual compounds which are separated will be ionized. They will be made to have charge. Okay, so they will be converted into charged particles. And finally, what you calculate is the mass to charge ratio. This mass to charge ratio would be unique for each of these compounds. Okay, and you have normative data also. So if you identify a substance with a mass to charge ratio which comes in the range of that of an androstenedione, you can identify that compound as androstenedione and you can quantitatively measure them. And if the mass to charge ratio comes within the range of 17-hydroxyprogesterone, you identify that the tested sample contains 17-hydroxyprogesterone at this concentration, and you have several graphs for that. Okay, the important point is that it is the most specific and accurate thing. You have the liquid chromatography for initial separation and the mass spectroscopy unit. Mass by charge ratio is the one that you specifically look at in a patient in LCMS method. Okay, so this is what we are doing here. In the liquid chromatography column, initial separation is done, and within the mass spectrometer, it is ionized, and later it is analyzed and detected. So usually we use, for blood samples, LCMS is what we use, and for urine samples we use GCMS. Only difference is the chromatographic column. So this chromatographic column has a stationary phase and a mobile phase. So based on the state of the stationary phase and mobile phase, you have the liquid chromatography and the gas chromatography, and there is no difference with regards to the mass spectrometer there. Okay, so for urine specimen we use gas chromatography, MS, and blood we use LCMS. Okay, and for all the steroid, polypeptide, glycoprotein hormones, this LCMS is the gold standard as a measurement. And a few points on equilibrium dialysis. So equilibrium dialysis, you just need to know one point here. Equilibrium dialysis is specifically to measure those analytes which exist in both free and bound forms. For example, T4. So T4 exists in free form and bound form. Okay, and testosterone, it occurs in free form and bound form. So these analytes, when you are using immunoassays for assessing the free hormones, sometimes the bound forms can also interfere with that based on the binding ability to the binding proteins. So in such patients, we filter them with the help of a semi-permeable membrane. You create an equilibrium between the two sides and then you measure the actual analyte concentration. So equilibrium dialysis is mainly used in measurement of free T4 and free testosterone. Only these 2 points you need to keep in mind. The procedure and all, have to go into too much of depth to explain that. So for the want of time, I am not doing that. So free T4, free testosterone is measured using equilibrium dialysis. Okay. Then one more point with regards to HPLC. So the three conditions or the three analytes where we use HPLC commonly in our clinical practice is one, to check HbA1c. Okay, to check HbA1c, then for catecholamines measurement, catecholamines and urine free cortisol. So these are the three analytes or the three endocrinological indications where we commonly perform HPLC. Okay, but HbA1c can be measured by immunoassay, catecholamines by LCMS, which is more accurate, urine free cortisol also by both immunoassay and LCMS is there. Of course, LCMS is the most accurate method for measuring the urine free cortisol. So summarizing, we have learned about the basic techniques in measuring the hormones, the different types of immunoassays we have learned, and what is the difference between sandwich and competitive immunoassay, which is by far the most common question asked. Then we have learned that the attributes of a good assay, the accuracy, precision, the limit of detection, functional sensitivity, the coefficient of variation and all that. When we have looked at the various assay interferences, starting from the biotin effect, the hook effect, the macro hormones and the various other antibody interference, etc. And finally, we have looked at a few points with regards to LCMS and equilibrium dialysis. So great depth, the knowledge into great depth is not required in laboratory endocrinology. You need to learn these basic concepts only, and I hope you will be able to answer all the questions from the laboratory endocrinology after seeing this class.